Nurse Talk Show. I am getting excited about everyone's excitement and involvement into the Nurse Mike Talk Show, the first Nurse Talk Show that will ever be designed like this, where we'll have nurses to speak on their behalf on what they think our challenges are today and where we should move today. I do know that we have a lot of federal, state, and governmental officials that make rules, make guidelines, but I am sure that they're not talking to the grassroots nurses that's in the emergency room, getting fresh diseases from psychoses on to gunshot wounds. I am sure they are not sitting at the same table talking to these nurses about how they respond in these situations when their patients are in the ICU, and we're speaking to the family and we're giving the information as best we can from some of the politics that arises from some of these incidences or some of these diseases. We will be sitting at our round table or square table, whatever table that they set us at. We will be discussing with nurses and their specialties about some of the choices that had to be made in order to have a favorable outcome, either for the family or for the patient's healthcare proxy. There's a whole gamut behind that statement. And I do want you to know that many patients have written to me already, and we've gotten a whole set of questions that are going to be addressed within the next segment of this show. And we'll answer them as best we can. We will also reach out for references. We will talk about statistics and where they come from, who's in those statistics, how they come about. So I am very excited about the Mike Nurse Talk Show, and hopefully you are too. We'll be having plenty of nurses call in their specialties and talk through Skype. Some will be nursing students. We'll talk today, though, about the elaborate portion of home care infusion, and how when you come into a patient's home and we have all this paperwork to fill out, or we have to type in a lot of information, how sometimes that can be distracting for the patient. And they feel that they can't ask all of the questions that they require. Sometimes you're there and they want to talk about many other different aspects of their other diseases, and therefore you're there for just the infusion of an antibiotic that's to run for 30 minutes to an hour, and they're thinking, how can I get a lot more in? And my suggestion is this: always make yourself available for questions, or give them references and the ability to find out more information about the particulars that they're asking. I was asked a question by one of my patients to ask this question: why are all the big agencies causing missed visits to their patients, and causing them sometimes to even miss their infusions? And my answer to that would be, nurses have to case manage their own patients, and this way they can set up the scheduling for the infusion, and the pharmacists themselves should also be responsive to the nurses' address to how that should be delivered. Sometimes these patients don't have doormen, they may not have someone at home, but the nurse themselves will be able to know that situation a lot better after a few visits. The best way, I always say, is to schedule ahead of time, that you're scheduling with your nurse and that pharmacist. A lot of times there's a lot of channels you have to go through, and I would love to see a lot of that weeded out. There's a lot of I don't know whys, and I don't know who the person I spoke to, because a lot of these people are told they can't give out their ID numbers, they can't give out any information, so it's very convoluted, and you're left kind of feeling like you're in some big corporation attacking your disease. So I always say it's best left up to your nurse to communicate most of your needs with that particular pharmacist and case manage you from the beginning to the end. One of the other questions that were asked for the provisions of home care infusion was the inability to contact pharmacists, and you're always contacting 3, 4, 5 people within your insurance company. Hopefully that as well will change. I don't see why so much of our patients' information, patient treatments are being discussed with so many different people opposed to a nurse and that pharmacist and a doctor. Especially the doctor. The doctor and the nurse and that patient should communicate all of their needs with that one nurse, and that one nurse can definitely have what is needed for that patient in the home for their implementation of that particular disease. So it could be from the history taking to the administration, but definitely that nurse should handle the entire outcome of that process. We had a third question, prescribing medication by pharmacists. Pharmacists have also been known in home infusion to take advantage of the fact that they may know the patient, and one of the things we don't want our nurses to do is to get laxed in thinking that because you have that prescription and you have that order that you don't communicate with that doctor to make sure any lab values or any of the treatment modalities are not missed, because some pharmacists have gone upon themselves as saying a frequent flyer, as they say in the medical field, frequent prescriptions or frequent turnarounds of those patients' treatment, and think that it's okay to continue to give it without the appropriate lab values, without making sure that the doctor is aware and the nurse is aware of these lab values and these treatment plans. We move forward towards making sure that patients are not re-hospitalized because we don't want them discharged inappropriately. Most of the times, if a patient requires home infusion, there's also other diagnoses that may be going on that may prevent the patient from being discharged from the hospital at that time. But certainly, if there are none, the cost of being discharged from your hospital. However, I do know from our own private experience that our nurses and our patients do much better without a lot of ancillary and misunderstood interruptions within that treatment. Patients are more compliant when they can communicate with their nurse. They learn a lot more for themselves and their family members to be able to move towards a better outcome in their care. We plan to, bridge the gap with many suggestions. I know most of the nurses that I have learned from have taught me well, and they have always assured us that safety is the most important thing. And with that, it's very important that the nurse has a handle on that prescription and not a pharmacist and not a doctor outside of where you're treating that patient. That patient depends on you to make sure that it is accurate, as you teach them to make sure that the drug was sent properly, and that the dosing as well is appropriate at that rate for that particular patient. So we look for many reasons to bring nurses, as skilled as they are, out into the home to prevent all these things that can happen to them. we want these nurses to be brought. Rehospitalization is at its lowest. Hospital-acquired infections are down to almost none. Healthcare practitioners not wearing their hospital garb outside and coming and maybe sitting on your bed, harmless as it may seem, and especially as personable as they want to make themselves, it's not the most healthy thing to do, especially with all of the diseases being trampled into your room just from a shoe, the clothing that they already wore outside, a lab coat, the stethoscope, the whole thing, but they're washing their hands, but all of this is now brought into your room because they wore it on the train, the bus, and in their cars. So it's best, to get back to that practice that I learned from those old nurses, that when they came to work, they came a half an hour earlier and they dressed in their hospital uniforms or whatever they were going to wear that day in a clean environment. It can't be sterile because you're not generally in a sterile area unless you're in the operating room or performing in some of the interventional areas, those types of procedures for you to be sterile. I can't wait until we get into more of the film aspects of our program, especially with nurses that are well seasoned, as I like to say, cream of the crop nurses that I've learned from. Many nurses today that I treat in their homes, many of the patients that are doctors or affluent people look at this field as a very elaborate way of preventing many types of mistakes within our healthcare field. It will keep down the cost. The hospitals need to really look at more of us to develop and bridge the gap. Wow, I am excited about some of these questions. One of the questions that was asked was, who should handle consults from my experience? Consults that they asked about are consults that when you come in a hospital, we'll consult with a specialist. The doctor will order an emergency room, a consult with a respiratory physician for a patient that comes in with respiratory problems to a patient that may need surgery. And a lot of times it's a physician that's affiliated with the hospital, and that whole billing process can override or come over onto a patient if the patient is not aware of how the billing process works for each institution. Each institution that you're taken to, the billing process is different. Also, the visiting and admitting doctors are different. So the consult generally comes from who is affiliated with that particular institution, who has admitting rights, and the billing can either be a separate bill or included in an itemized bill to that hospital. So consults vary, and from my experience, they have to be discussed from the aspect of whether or not that particular physician is proficient in what is being recommended for that disease process, as well as whether or not this is going to be a cost, an extra cost, because they are affiliated with that hospital or not affiliated with that hospital. There was another question that was asked that was pretty interesting about the radiology, CAT scan, and nuclear studies. Who should get the results after these are done? Depending on the diagnosis, the primary care treating physician is the doctor that generally gets that particular evaluation, but the actual film themselves have to be requested, which is another trying experience for a lot of patients in the process of billing when they receive a bill and it's separate from their hospital stay, separate from their visit from that doctor, and it can be very confusing on how to get that actual film read and seen by a independent person, a person that should not, absolutely should not be within that same network. Because case in point, if that physician is in the same network, the two of them can agree, and the one that's outside the network can disagree without ever knowing any of the two suggestions of surgery. I had that experience personally. Right now, I don't need surgery on my feet, as they said, but the independent practitioner that I went to and gave him the opportunity to examine me and get these nuclear and X-ray scans and the CAT scan and read them ourselves. We were able to see that I didn't need surgery. I had some swelling that was causing me pain, and I needed some anti-inflammatories to stay off my foot, and to buy an orthopedic shoe or buy some really good shoes that are out there, some sneakers that are out there, as I was walking around the emergency room all day. Those suggestions worked, and I didn't need surgery. But two physicians within the same network did recommend that I had surgery. I have that documentation, and I often refer to it, and that's why I find it very difficult to have networks be the sole source of billing and having the insurance company look at a network of doctors favorable to an outside or an independent practitioner. Moving right along, there was two more questions, and one of them was, why can some of these procedures that are done in the hospital setting not be done at home? Well, lots of radiology procedures can be done at home. I'm noticing that some of my affluent clients have actually had them done at home. I don't know what specifics are involved in having these mobile transports and a secure radiological guards like the thyroid shield and the pelvic shields, how they are looked at in home care. I haven't done enough study on them, but I do know with my idea, my business plan, we do EKG monitoring with patients that don't have pacers because they're able, if you have a more in-depth and more, usually they're very expensive model of EKG, 12-lead EKG, you can do them in the home. You can do cardiac monitoring. You can do pulse ox monitoring. We can do cardiac monitoring. They even have home dialysis machines. They have all types of home care services. I don't know why the bridge isn't done successfully already. There must be a reason. Generally it's financial, but I am sure that it is less costly than having to go to a hospital, opposed to transport of these materials and the safety of this being secured in many, many homes. Some, I'm sure, with elevators and that we talked about, they won't happen unless they're a lot smaller portable machines. The last question was, what is the difference between skilled nursing and high-tech nursing? Not much of a difference, other than high-tech nurses, as we viewed, were the nurses that did invasive procedures into vascular systems with chemotherapeutic agents, anti-neoplastics, antibiotic agents, different types of drips, IVIG. Many of these drugs go intravenously and need to be monitored according to the patient and not according to a pharmacy's generalized scale, because sometimes those infusion rates, those particular drugs can affect other organs, like all medications can. And it's very important that a nurse is observant and able to assess the patient on the entire scale of its side effects or new developing side effects or untoward effects of these types of intravenous medications. So skilled nurses generally are nurses that do more wound care, medication preparation of medications that go in your mouth, or topical or optical in your eye, topical for your skin. Many different types of differentiations are done, but on a whole, high-tech nurses generally have a nursing background in ICUs, in interventional areas of study, ERs, and these nurses have a different background. I guess high-tech would be considered towards the calculations that are regularly and often done in infusion. I want more involvement from nurses, because when I get on a daily basis a visit from that experience that I had with my sister at the bedside, if a nurse was there, her life would have been saved, my sister's life. I want to thank you all for watching, and as we continue to develop our show, I hope that you will continue to watch. You know you're a nurse when you greet your patient and it's in the afternoon and you say, "Hi, good morning, how are you?" You used to work long hours and shifts in the evening, and now it's in the morning and your patient is on the floor. I have another joke for you. A blind guy came into our emergency room for medical treatment, and the doctor says, "What happened?" asked the doctor. "Well, my wife was ironing while I was watching the ball game on TV," began the man. "She put the hot iron near the telephone, and when the phone rang, I answered it, but I answered the iron." The doctor nodded. "But what happened to the other ear?" "Well, no sooner than the phone rang again," said the man, "I picked up the iron again."